Olá. Ok. Oi, pessoal. Bom dia a todos. Queria agradecer a presença de vocês aqui nesse sábado, né, prestigiando nossa atividade, o início das nossas atividades. Eu sou o Felipe, sou professor de Pathologia na UFMG, em Belo Horizonte, e faço parte da equipe da diretoria atual da Sobep, e junto com meus colegas da direção da sociedade, nós estamos organizando um ciclo de palestras, né, um ciclo de aulas, que vai dar continuidade às atividades virtuais que foram iniciadas com a professora Manuela e toda a equipe que trabalhava com ela na administração anterior, e que a gente entende que é muito rica e contribui bastante para o nosso aprimoramento profissional, para a manutenção das nossas atividades acadêmicas. Naquele período de pandemia, e agora, à medida que a pandemia vai começando a ser mais controlada. Então, eu queria convidar vocês sempre a participar das atividades. A gente vai ter uma aula por mês, certo? Essas aulas serão sempre aos sábados pela manhã, por um motivo muito simples. Nós temos convidados internacionais, vários, né? Já temos toda a nossa programação consolidada, e muitos deles são de fora do país, e há variações no fuso horário, né? Então, é muito mais fácil a gente adaptar os nossos horários no sábado do que durante a semana. Então, nem todas as aulas serão às 9 da manhã, algumas serão pela parte da tarde, mas sempre aos sábados. Né? Espero que essas atividades sejam úteis para vocês, espero que vocês aproveitem ao máximo e que a gente possa desenvolvê-las de maneira perene, né, na nossa sociedade. A professora Águida, que é a nossa presidente, né, ela mandou eu enviar saudações para vocês, um abraço forte, e também dizer que está muito animada com o desenvolvimento dessas atividades. Bem, para hoje, a gente vai receber o professor Liam Robson, que é da Universidade de Pretoria. O professor Liam é nativo em inglês, né? Então ele fala inglês, a aula dele será toda em inglês. Então eu vou, depois dessas breves palavras em português, eu vou apresentá-lo e introduzi-lo para vocês em inglês, ok? Well, Liam, I'm going to introduce you now. Good morning to everyone, and we are today receiving Dr. Liam Robinson. He's a neuropathologist, oral and maxillofacial pathologist at the University of Pretoria, and he works with our colleague, Professor Willie van Heerden, and we are always very happy to receive our colleagues from Pretoria, from South Africa, in our in our Sobep environment, no matter if it's in person or if it's online. Then, Liam, we're very happy to have you here. And Dr. Liam, in addition to his oral pathology activity and oral medicine activity, he's also a very active professional in oral radiology and in dental forensics. So he's got a very distinguished experience with these fields of dentistry. And he's going to talk to us today for more or less 50 to 60 minutes. And then after his talk, all of you are very welcome to send us your questions, your doubts. I will translate them to Dr. Liam, and then I'm quite sure that we're going to have a very good moment of discussion after his talk. Okay. Please, Liam, be very welcome. Take your time, suit yourself, and thank you very much again for supporting us and for joining us in this Saturday.
Thanks, Professor Felipe. I really appreciate it, and I look forward to the presentation. And thank you for having me on this platform and with the society. Our relationship with the Brazilians is really a symbiotic one, in that the research that we have produced together is really something that I think is excellent, and we really appreciate the opportunity that we get to collaborate with all of you in Brazil. And we're looking forward to many more collaborations in the future. I must also say that the research coming out of Brazil is really something quite excellent, and I think that you guys have really positioned yourself to be really on the forefront of oral and maxillofacial pathology, as well as oral medicine in around the globe. So I really do appreciate the opportunity to present to you. The presentation that I have for you this morning is entitled Second Look Pathology, Rare Findings in Routine Cases. And the purpose of this talk is that it will be around 5 cases, and these cases are where the overall features were not entirely in keeping with what you would think would be the obvious diagnosis, or where the diagnosis seemed initially quite straightforward, but on closer look, you find really quite pertinent additional findings on the histopathology. I will take you through a diagnostic workup of the cases with some relevant references of the literature, as well as some of the latest ancillary studies that are available. So because time is short, let us get straight into it with the first case. So case 1. Case 1 was that of a 19-year-old female who presented to our clinic with a 6-month history of a painful swelling involving the posterior mandibular region. Now, at this stage, the maxillofacial surgeon was uncertain whether the lesion or the swelling was that of an intraosseous lesion or purely a soft tissue lesion. On their examination, they noted that it was quite firm and fixed on palpation, measuring approximately 4 centimeters in diameter. The patient showed quite extensive trismus, and the teeth in that vicinity showed quite severe displacement. So this was the clinical image that we saw of the patient when we visited the clinic to have a look and give our opinion. You can see really quite a large swelling involving the right side of the face. On this lateral view, you can certainly see the extension of the swelling in the anterior-posterior direction, but it really is uncertain whether it is a soft tissue or an intraosseous lesion. As I mentioned previously, the patient had quite severe trismus, but you will note that there is certainly displacement of the maxillary teeth in that region. So as part of the workup, a panoramic radiograph was taken as the baseline image, and this showed a mixed lesion with destruction of the maxilla, as well as the maxillary sinus, zygomatic arch, and of course the ramus. Again, from this image, it's uncertain where the origin of the lesion is occurring. We then referred the patient for Cbct imaging, and this is a 3D reconstruction of the case, which you will note on this case that you have a soft tissue lesion with extensive calcifications and erosion of both the maxillary bone with loss of the teeth and the posterior mandible. An axial view showed a lesion of soft tissue density with extensive internal calcifications that caused destruction of the sphenoid bone, zygoma, as well as the maxillary sinus. On the coronal, you can see there is extensive involvement of the condyle, as well as encroachment of the middle cranial fossa superiorly, as well as medially a narrowing of the airway. So the maxillofacial surgeon at this stage took an incision biopsy for a diagnosis, and the reason I put this in is purely to show how the macroscopic examination or your grossing at your bench can also be helpful in the workup of a case. So what we received was several hard and soft tissue fragments. The largest was really a mixture of soft tissue and bony calcifications, whereas the smallest fragment was really just bone alone. This is the histopathology of the bony fragment that we received, or the hard tissue fragment. And you can see from this image that we just have masses or conglomerates of bony tissue with minimal intervening fibrous connective tissue, and really no evidence on this image of any cellular tumor. What we noted on this image was scattered areas where you have within the fibrous connective tissue, you have these spindled to more oval cells, which are quite cellular, but bland in cytology. Again, another area showing the cellular tumor adjacent to the hard tissue aggregates. Another image where you can see the cellular tumor intervening between these hard tissue fragments. You can see the quite prominent and irregular reversal lines that are apparent on the bony fragments. So on a quick look and around the microscope, you may consider the diagnosis of an osteoblastic osteosarcoma. We certainly did. It's the right age. And with that sort of irregular bone, it certainly is one of the top differentials. However, those calcifications that we see in our case really do not seem to fit with the classic calcifications that you can see in this image of an osteoblastic osteosarcoma. Also, the background cytological atypia, as seen in this case of an osteosarcoma, is quite severe, whereas in our case, the morphology was bland with monotonous spindle to oval cells. Really, we had to search for mitotic figures. With that bony calcifications, you may also consider the diagnosis of an osteoblastoma. We know that an osteoblastoma shows varying degrees of mineralization along its biological course. And you will agree with this image of a classic case of osteoblastoma that those calcifications could fit the calcifications that we see in our case. However, the radiologic features certainly do not fit with what we were presented with. So we proceeded then to perform quite an extensive immunohistochemical panel. Before we get to that panel, this was the tissue fragments of the soft tissue and bony material that we had on grossing. And here you can see the extensive cellular tumor, which on a higher magnification shows spindled cells, which are bland with an open or clear vesicular nuclear chromatin, as well as some blood vessels scattered in between. Here you can see the monotonous characteristics of the cellular tumor, which really has no pattern, but you can see that you have spindled cells with some cells in between which were slightly more plump and more aggregated. So on that, with the age of the patient is 19, we also considered the diagnosis of a mesenchymal chondrosarcoma. Now, this prototypical example of a mesenchymal chondrosarcoma shows the small round blue cell tumor in association with the neoplastic cartilage. And certainly in our case, on hunting through all the sections that we put through, we had no evidence of cartilage differentiation. Also, the cytological atypia that you may see in a mesenchymal chondrosarcoma is quite severe, whereas in our case, it is monotonous. In areas you had this vague fibrillary type eosinophilic material, which was amorphous, and that was interspersed between the cellular tumor. Here you can see some more images of that material interspersed between the material, vague, starting to come up a staghorn-like blood vessel vasculature in the background. But also in the soft tissue cellular tumor, we had these aggregates of calcified material. Again, to show you that fibrillary material, and I will say at this point, we did run a Congo red histochemical stain, as well as a theoflavin T immunofluorescent stain to rule out amyloid, which in this case was negative. So you may even interpret this as some osteoid in the background. And on this image, you can see quite prominently the so-called staghorn or hemangioparasitic vasculature that we have in this case, with this interspersed amorphous eosinophilic material. So moving on to our immunohistochemistry, we began by performing a Chi-67, which was really quite low as a proliferation index in this case, which further cemented the concept that we're not really dealing with an osteoblastic osteosarcoma. We then went on to do an AE1, AE3 pancytokeratin, which highlighted those scattered, larger, more plump cells, as well as some of the spindled cells in between. A high power magnification shows you those, let's call them epithelial cells now, which were slightly larger and more plump. We followed that up with a EMA, which highlighted more of those plump, more coalescing cells, which were more plump and epithelioid in appearance on the H&E stain. We then performed a Vimentin, which I know gets a bad rap in soft tissue pathology, but in this case, it was quite helpful, showing that the spindle cell, as well as the epithelioid cells, showed Vimentin positivity. And you can quite clearly see that in these images. CD99, slightly overstaining, but showed diffuse membranous positivity in all the cellular tumor. We followed that up with a TLE1, which I've put with an asterisk, and we will address that asterisk later on, which showed strong and diffuse nuclear positivity throughout the neoplastic cells. Another high power magnification, it really is a very strong nuclear stain in this case. It was even stronger than our control. So in our molecular laboratory, we were quite fortunate to have an SS18 break apart fish, which we got actually for the microsecretory adenocarcinoma after the Bishop article found it to be a reliable marker for that new salivary gland tumor. But we also use it obviously for synovial sarcoma. And in this case, it showed that the vast majority of neoplastic cells showed a really nice break apart. So at that stage, we were confident of our diagnosis as a biphasic synovial sarcoma. However, the calcifications caused us some problems with regards to a rare variant of the entity. That was quickly sorted out via a quick internet search, where we got these three really excellent references. The first one from Enzinger, which is no need as an introduction as soft tissue pathologist, and two others which had quite extensive cases. So this is the image from one of the articles. It was an article in Histopathology in 2001 of a calcifying or ossifying synovial sarcoma. And there indeed is the image in black and white, showing very similar features to the current case described. Now, what was important was from the Enzinger article in 1982, which may seem rather old, but it still is up to this date, the most extensive article with the most number of patients evaluated. They had 32 cases in their series of extensively calcified synovial sarcoma. And what they found was it really showed the same age incidence and location as a conventional synovial sarcoma. Most of them showed at least some evidence of a biphasic morphology. But most importantly, from this article, the 5-year survival rate was considerably better than the reported 5-year survival rate of traditional or conventional synovial sarcoma. And that is, of course, important to relay to the surgeon when he communicates with the patient regarding the prognostic significance. So from this first case, some of the learning points that we can gather is that there are rare histological subtypes of synovial sarcoma, indeed the poorly differentiated, which has the worst prognosis. In the new WHO terminology, they like to term it as a round cell synovial sarcoma, the calcifying or ossifying variant in this case, and then also a myxoid variant. And in about 1/3 of synovial sarcomas, there is areas of calcification, and this calcification typically shows a lace-like pattern of osteoid, which may mimic an osteosarcoma. So that certainly is a caveat in these cases. And although the speckled-like calcifications, which are typically seen in synovial sarcomas, in those that are calcified extensively, that bony tissue can mature to the point of it being lamellar or even trabecular. And as I mentioned previously, as is the case with many immunohistochemical stains, when TLE1 was released, we thought it would be a very sensitive and specific marker for synovial sarcoma. However, it is no longer the case, and TLE1 can also be seen in cases of malignant peripheral nerve sheath tumor, as well as solitary fibrous tumor. And this was partially solved by a very recent article by Jason Hornick and his group, looking at the new fusion-specific antibody SS18SSX, which is now available for immunohistochemistry. And in their article, which was published in the American Journal of Surgical Pathology, they found that strong and diffuse nuclear staining was seen in 95% of cases of synovial sarcoma, but importantly, none of the 300 control tumors revealed any staining. So it really is a good marker now for synovial sarcoma, and probably makes the fish in this case redundant. However, that fish is still useful for other tumors like the microsecretory adenocarcinoma, which is the new salivary gland tumor. So that is the end of the first case, and I thought for those of you who haven't visited our country and our institution, this is a bird's eye image taken of the area in which we are located. You can see here within the square block, that is the Oral and Dental Hospital where we are located on the 6th floor. You can see it is adjacent to this large building, which is Steve Biko Academic Hospital. That is one of the largest hospitals in South Africa per bed size. It has over 1,000 beds. So you can see we are positioned in that location, adjacent to the basic medical science building where all the students do their basic medical training. Moving on swiftly to case 2. So case 2 was that of a 44-year-old female who presented with an 8-month history of painless nodular lesions in the hard palate and gingiva. And the clinician noted upon examination that these nodular lesions bled quite extensively on manipulation. Now, if I show you the clinical image, I'm pretty certain that the vast majority of you will really have a diagnosis in mind already on this case. It really does look like a classic example. But you can see these nodular lesions involving both the hard palate as well as the gingiva. Again, if I show you this histomorphology image, on low power, you can see it's a nodular spindle cell lesion, which really shouts out the diagnosis. But further still, I will show you the high magnification, these slit-like vascular spaces that are created by the spindle cell neoplasm, which in areas shows these eosinophilic hyaline globules. And you'll take my word for it, but there were quite extensive plasma cells in the background. The diagnosis is, of course, confirmed by an HHV8 stain, which confirms the diagnosis of a Kaposi sarcoma, which I'm sure none of you had any diagnostic problems with. However, in this case, the interesting feature is what was lurking on closer examination. And here on this low magnification, you can see 3 cells which are larger than the surrounding infiltrates with quite weird nuclear features. On a higher power magnification, you can see their nuclei look rather enlarged, eosinophilic in this case, really don't fit with the typical inclusions that you see, but the location where these inclusions were found close to a blood vessel is quite characteristic of this virus. If you looked more throughout the tissue, you will notice that these were quite extensive in this case. And again, the diagnosis is confirmed via a CMV immunohistochemical stain, which highlighted these viral cytopathic effect in close proximity to the endothelium, as is characteristically described. So the final diagnosis for this case was that of a Kaposi sarcoma with concomitant CMV infections. In South Africa, we have a really excellent dermatopathologist. His name is Professor Wayne Grayson, and he wrote this in combination with another fellow South African who had since relocated to the US in diagnostic pathology on the histological variants of Kaposi sarcoma. Professor Grayson has a great interest in Kaposi sarcoma. This was published in 2008. And as I mentioned in the beginning of the talk, we really are privileged to do a lot of collaborative work with you guys in Brazil. And this was a collaborative article from our institution, but with Professor Vargas on the microscopic diversity in oral Kaposi sarcoma. And indeed, this is where the case was reported of the concomitant cytomegalovirus inclusions. Professor Grayson further published an article in Pathology Research International on the recognition of dual or multiple pathology in skin biopsies from patients with HIV and AIDS. And you'll note this table from the article showing all the different infections that were seen in association with Kaposi sarcoma, including CMV. So the learning points from this case is that there are many histological variants of oral Kaposi sarcoma, as per the article I referenced. The solid lymphangioma-like telangiectatic, lymphangiectatic, ecchymotic, anaplastic, and indeed in that article they describe a new variant, the desmoplastic variant. In addition, there are other variants which have been described only in cutaneous or dermatopathology of the bullous or hyperkeratotic, colloidal, pyogenic granuloma-like, and intravascular. And I think what the important take-home point from this is when you have a case of Kaposi sarcoma, look for coexisting infections, dermatoses, as well as neoplasms, because they have been described. So be on the lookout for the subtle clues, as was seen in this case. So this is a photo of the entrance to the Pretoria Oral and Dental Hospital, and I've again highlighted in the box, this is the 6th floor. That is where our department is located, and you can see these offices are all the individual members of the department. Professor Van Euden's office is right at the end. Moving on to case 3. So case 3 was that of a 33-year-old male with a known history of HIV disease, with a high viral load and a very low CD4 count. The patient presented and gave a history of a 2-year history of cervical lymphadenopathy and generalized lymphadenopathy that he described as coming and going. The patient also reports previous history of night sweats and weight loss and was treated for pulmonary tuberculosis. So the clinician took a biopsy of the cervical lymph node, and this is that. On low power magnification, you can see that we have a lymph node where the architecture is distorted, however, the capsule is still intact. And even at this low magnification, I think a lot of you will already be considering the diagnosis. On closer magnification, you can see there is replication of the mantle zones of the germinal centers with quite a cellular infiltrate in the interfollicular space. On a high magnification, you can see that onion skinning appearance of the mantle zone with, again, quite a rich plasma cell infiltrate in the interfollicular zone, quite prominent tingible body macrophages as well. There are some evidence of some endothelial venules in the background, as well as the extensive plasma cell infiltrate. So I think at this stage, no one has a problem with the diagnosis of Castleman disease. Which type it is obviously depends on the clinical, and I will reference that a little later. However, what we saw in this case were areas where the cellularity was much less, more fibrotic, and on closer magnification forming these slit-like vascular spaces with extravasated red blood cells, as is indicated on this image, some atypical mitotic figures scattered, and a HHV8 stain was performed, which was beautifully positive, again in that area. The HHV8 stain also stained some of those plasmablastic cells which are seen in the interfollicular zone, but also permeating within the follicles. So with the clinical history and the immunohistochemical staining characteristics, we have a HHV8 associated multicentric Castleman disease. So the learning points for this case, according to the latest WHO, Castleman disease is divided into three entities: the unicentric Castleman disease, where you have the hyaline vascular variant, the so-called lollipop appearance on histomorphology, as well as the mixed or the plasmacytic variant. And on a clinical examination, that involves a single lymph node or a single group of lymph nodes in one particular region. Then you get the idiopathic multicentric Castleman disease, where two or more lymph node sites are involved, but you have to rule out some of the other entities or diseases such as HIV infection, Kaposi sarcoma, and other forms of Castleman disease. These patients also have a hypercytokemia, which is that of a cytokine storm, in particular interleukin 6. The last variant is that of the HHV8 associated multicentric Castleman, which is this case. And again, they are associated with systemic inflammatory symptoms, again due to the cytokine storm. A really excellent article from Blood looking at evidence-based consensus for the diagnostic criteria of HHV8 negative. So this is the idiopathic multicentric Castleman, because that is the real one that you have to exclude in most instances. You can see on the left-hand side, this Venn diagram, all the entities that you have to exclude to make a diagnosis of the idiopathic variant. Again, an algorithm in the form of a flowchart of a patient presenting with Castleman-like features in a lymph node, and how you clinically distinguish between unicentric and multicentric, and then exclude all the entities to get to a diagnosis of idiopathic. Here in this case is our example of the HHV8 associated. So the learning points from this case continued is that foci of conventional Kaposi sarcoma are often present in the HHV-associated multicentric Castleman disease. And there has been quite a lot of literature in the past and now more recently in the present on lymphomas arising in the multicentric Castleman disease. In the latest WHO, the large B-cell lymphoma arising in HHV8-associated multicentric Castleman disease is considered an obsolete term, and they prefer to use the term HHV8 positive diffuse large B-cell lymphoma. This lymphoma is nevertheless an aggressive lymphoma, and those arising in the background of multicentric Castleman have a median survival of only a few months. There's also been a recent article published in 2020, which was rather interesting, looking at Hodgkin lymphoma arising within a classic subtype in multicentric Castleman disease. So this is a nice article looking at the prevalence of coexistent pathology within multicentric Castleman disease, and there indeed you can see in about 40% of their cases they had a Kaposi sarcoma. Non-Hodgkin lymphoma was much less prevalent. This is that interesting article from Vircho's archives that I referenced previously, looking at classic Hodgkin lymphoma and Castleman disease, an entity which appears to be emerging. And what they found was, in their literature review, that 34 cases of coexistent classic Hodgkin lymphoma and Castleman disease, about approximately 2/3 of them have been the so-called interfollicular variants of classic Hodgkin lymphoma, which is a variant that is not even referenced yet in the WHO. It's so rare. And about 90% of the Castleman disease cases were those of the plasma cell variant, but HHV8 negative. And they postulated that this interfollicular variant of classic Hodgkin, as well as the plasma cell variant, may be a distinct entity with a common pathogenesis related to the dysregulation of the cytokines, in this case, the interleukin 6. So really a entity that's not really well established yet, and I think definitely more research needs to be performed in this regard to further look into this entity. Really, at the University of Pretoria, we are quite privileged to have some really amazing buildings. This is the Twelepele building, which is a more recently built building. It's really quite beautifully done architecturally, and it houses a lot of offices as well as human resources and student administration. Moving on to case 4. Case 4 was that of a 39-year-old female with an asymptomatic cystic lesion in the right posterior mandible. The lesion was enucleated under local anesthetic. What we received was the periapical and panoramic radiograph, and what you can see is a well-defined radiolucent lesion in the fourth quadrant situated between the 4, 5, and 4, 6. There certainly is some root resorption of tooth 4, 5. As I said to you previously, the lesion was enucleated. And on some of the histomorphology images, these are some high power of what was a cystic lesion with a nice lining. Certainly you can see even from this image that we have a ameloblastomatous lining, quite prominent reverse nuclear polarization and subnuclear vacuolization. So really quite prevalent ameloblastomatous type epithelium. Again, a closer magnification, and really the diagnosis, we had the whole lesion, it was enucleated, so we felt very comfortable at that stage to call it a unicystic ameloblastoma paired with that radiological images. We know that there are many articles referencing hesitancy to call it a unicystic ameloblastoma unless you have, like in this case, the whole lesion and some radiographic support. So we were quite happy to call it that. However, interestingly, in this more representative area, which I didn't show previously, but here we have numerous multinucleated giant cells seen in the wall of the cystic lesion. And this was a peculiarity that necessitated further reading up. Again, quite prevalent within the wall of the cyst. We performed a CD68, and you can see beautiful positivity within these multinucleated giant cells, which confirmed their histiocytic nature. So the final diagnosis in this case was that of a unicystic ameloblastoma with stromal giant cells. And indeed, Prof. Fonseca, Prof. Felipe will know this case. We recently published it in OOO, along with one of his cases that he found. They are really quite exceedingly rare in the literature. So what I think is quite a nice article to read up. The learning points from this case is back in 1964, Boss reported 3 cases of giant cells in ameloblastomas. What was interesting is that there have only been 3 cases in total of unicystic ameloblastoma with stromal giant cells, 1 by a previous group and 2 from the current article, which was collaborative between South Africa and Brazil. The origin of these giant cells is really a debated point. Boss considered them osteoclastic in response to the bone destruction by the neoplasm. Other further references have considered them being histiocytic in response to the bone invasion by the ameloblastoma. And I think what is the most accepted is that of Richard et al., which considers them a response to the woven bone seen in the fibrostroma surrounding the ameloblastoma. And this was confirmed by their negative staining in his study for cytokeratins, positivity for CD45/LCA, CD68, and to exclude osteoclastic cells, HLA-DR. So that was the fourth case. The next is, again, just to show you some beautiful architecture from our university. This is our cafeteria, which is being recently remodeled to show you the student facility. You can see it's quite empty. This was in COVID times, but they put up these beautiful circular structures to shelter students from the sun, which can be quite extensive in Pretoria. Moving on to the last case, case 5, was that of a 53-year-old female who presented with a 3-year history of a slow-growing mass involving the left submandibular region. She reported that it was intermittently painful, and I'm not sure about your experience in Brazil, but we often get this history that after numerous consultations with medical general practitioners, the lesion showed no resolution after courses of antibiotic therapy. The patient was seen by a maxillofacial surgeon, and the superficial and deep lobes of the submandibular gland were excised. So what we saw on the routine panoramic radiograph was irregular soft tissue calcifications superimposed over the left angle of the mandible. You can see them highlighted here in the circular structure. And indeed, from the 3D reconstruction, axial and coronal views of the CBCT, the calcifications are arranged in a circular fashion and positioned lingual to the ramus in the vicinity of the submandibular gland. You will also note a vague soft tissue mass on the axial and coronal slices. So again, on the morphology of the lobes from the submandibular gland, again, we can see it indeed is a salivary gland neoplasm. Even on this first image, it's quite easy to see. You have 3 cell types here, with including mucus cells, your more epidermoid cells, and then those with the slightly smaller compressed nuclei being your intermediate cells, in quite a compressed fibrous connective tissue stroma. Here you can see the cystic nature, indeed, with all the mucus cells lining those cystic structures. Again, some of the multicystic areas, there were multiple areas where it was more solid in its architecture. The cytomorphology was bland, mitotic figures were not abundant, but there were some areas of perineural infiltration by the tumor cells, and indeed the grading of this tumor was that of an intermediate grade, mucoepidermoid carcinoma. I don't really have much time to go into the grading systems, but really in this case it was, we graded according to the Brandwein grading system, which is what we use over here, and it really fitted into the intermediate grade classification. But what was interesting in this case was there were extensive areas where that more eosinophilic material was undergoing calcification in the form of bone metaplasia. And you can see on this image quite beautiful lamellar bone deposited in between, with the tumor infiltrating into the bony structures. So that accounted for the radiographic features that were seen on the imaging. So the final diagnosis in this case was that of an intermediate grade mucoepidermoid carcinoma, with the additional finding of metaplastic bone formation. Now, calcifications are something that have been discovered in mucoepidermoid carcinomas, indeed by this excellent article, again by Brazilians, including Professor Vargas, as well as Professor Alan Roger. And they had 6 cases, 20% of their 30 mucoepidermoid carcinomas that showed calcifications. We recently published this in the form of a radiological report in Oral Surgery Journal, where we called it a mucoepidermoid carcinoma with metaplastic bone formation, a deceptive radiological presentation. So the key pointers are that these findings are rare. Only 12 cases of mucoepidermoid carcinoma with intratumoral calcifications have been reported in the literature. Interestingly, and I'm not sure why, but most frequently in conventional and clear cell variants, and mostly involving minor glands of the palate. Some proposed theories for these calcifications were that they are part of the tumoral component. They are metastatic calcifications in secondary to hypercalcemia, dystrophic calcifications of necrotic areas within the tumor. Of course, that postulate only works in cases where you have necrosis, which we know in many cases is not a finding in mucoepidermoid carcinoma. And then fourthly, which I think is the most supported theory indeed by the article by Vargas et al., is that dystrophic calcification of the mucin secreted by the tumor cells. Now, interestingly enough, mucoepidermoid carcinomas with intratumoral bone formation is even rarer, 5 cases, 3 of which are from that essay article that I previously showed you that's recently been published. What is further interesting is that the South African article includes the first case that these bone formation occurred within minor salivary glands. And again, some more proposed theories is that those dystrophic calcifications form a substrate for the osteoid organization, or there is some form of metaplasia of the stromal cells within the mucoepidermoid carcinoma to undergo transformation into osteoblasts and deposit the bone. But nevertheless, on those theories, the important key point from this case is that the radiological features may be even interpreted as intraparenchymal cellulus involving the submandibular glands and left alone, which would be quite disastrous for the patient. So that is the end of my talk today. I thought I would share some different generations of images. This is around our multi-header microscope within our room, our microscope room on a Friday when we look at our slide exchange boxes. And you can see some, what I hope is familiar faces in some of the images, as well as some of the regular staff within our department. Thank you for your attention, and I appreciate the invite to this society talk. And I show you a final image of the jacaranda trees blooming in Pretoria, which I was made aware of this week. That is a tree that actually originates within Brazil, so I'm sure you are aware of it. So thank you again, and yeah, I'm looking forward to the questions.
Thank you very much, Leah. It was amazing talk again. Superb presentations, and the images and the cases always very perfect. And we always learn a lot with you guys from Pretoria in South Africa. And again, we're very grateful for your participation with us today. Thank you very much, and congrats for your talk. It was brilliant. And our colleagues that watching us in the YouTube channel, they agree with these comments, and they also say that the lecture was great again. Well, we have some comments, some questions, not many questions, but I believe that some of them are very interesting, and I would like to share with you. We have some comments from Ana Luisa that she works and studies in Piracicaba. You might know her, and she asks you excellent cases. And do you run a HHV8 for every Kaposi sarcoma cases, even if you have the classic clinical and microscopic presentations? Is that a regular working feature that you run in South Africa?
Well, I think that's an excellent question. We have quite a fair number of Kaposi cases in our population, and certainly if it has the characteristic clinical features with the characteristic histomorphology, the HHV8 stain is something that we are struggling to attain, so we don't perform it as a workup on all cases. But those that deviate, we've had some rather strange Kaposi sarcomas that really you would think of many other tumors before you get to the diagnosis of Kaposi. So we do run it in those cases. But that's an excellent question.
Yeah, and she's got another question, another comment about the same case, number 2, but now about the pathogenesis of the tumor, of the lesion. You showed us the cytomegalovirus, right, in your images, and she wants to know if, in your opinion, of course, do you think that cytomegalovirus, the CMV, plays any relevant role for Kaposi sarcoma, or was it a coincidental finding associated with the low CD4 count of the patient or in HIV patient? Do you think that CMV's got any kind of pathogenetic role in these lesions?
I don't think so with the rarity that we found in them, but I think with Kaposi sarcoma, especially in some of our patients where our CD4 counts and our viral loads are quite high, that the CMV plus many other coexisting pathologies like candidiasis we've seen cases where you have granulomas, both non-necrotizing and necrotizing. We've seen cases of TB as well in Kaposi sarcoma. So I think they are just coexisting infectious entities.
Yeah, and just to complete the comment, you can find in literature some other lesions that share the same viral association, like, for example, plasmablastic lymphoma, for example, very strictly associated with Epstein-Barr. But you can also find in some cases cytomegalovirus and some other coincidental infections. But so far, none of them are considered pathogenetic for the tumor, for the lesion. But
Absolutely.
That's very, very interesting to find these coincidental infections in these lesions. Well, I have one question for you in case 1. That's just a simple question, but you showed us very beautiful images during your talk, and one of them was the fish images that you carried out in Pretoria to evaluate the SS18 fusion. How easy or how difficult is it for you in Pretoria to access these facilities for performing the diagnosis of oral lesions?
Yeah, it's also an excellent question. It's something we struggle with. We have quite a good molecular laboratory. Certainly compared to some of the other laboratories in South Africa, we're quite privileged to have an excellent laboratory technician that can run these molecular studies. We have a small batch of fishes that we can perform, but with the funding nowadays, it's getting more and more difficult to get hold of these probes. But yeah, we actually, as I said, we got that fish, the SS18, when we were screening at some of our adenocarcinoma NOS of the salivary gland. We were trying to look for that microsecretory adenocarcinoma when that entity came out. So we got it for that reason. But as you know, of course, it can be used for the synovial sarcoma as well. But yes, we have a panel of some of the break apart probes. We have BCL2, we have BCL6, we have MIC. That's for some of those lymphomas. We have the MAML2 that we've performed on our muco-EPS. I think we have ETV6 as well with the SS18. So we have a fairly decent panel. Of course, EWSR, which was one of the first ones we got.
Great, thanks. We have some very nice comments for you here in the chat. We've got some comments from Alan Piracicaba, and he's congratulating you in that very polite way of writing of Alan, and thanks, Alan. And then and he's sharing another comment that I think that's very important to you. It's very good to see a new young pathologist working in a very high standard, and I agree with Alan. It's very good to see someone very, very young with this talent and this experience.
Thank you.
And he's got one question for you. Can you please comment on how the medical treatment of HIV patients in South Africa works in the public health service of the country?
Yeah, I would speak under correction, but it's not really something that we are actively involved with. But the patient is, once the diagnosis is made, in the public sector, the patient is seen at a so-called HIV clinic where they are constantly monitored on a regular basis for their routine bloods, their viral load, their CD4 count, as well as things like the glomerular filtration rate, which we monitor, and the routine blood work. And they come on a regular basis to receive their ARV medications. And we take it from there. Obviously, we have different lines of ARVs, first and second line, depending on the particular case. Unfortunately, we still see quite a lot of people in South Africa that default on the medications, and that's when we see these aggressive B-cell lymphomas and plasmablastic lymphomas.
Yeah. Liam, I've got another question for you, very simple again. In the case 3 about Castleman disease you showed us, you commented about the name, the term used for some cases of lymphomas associated with HHV8. And I would like to ask you if you look, if you guys in Pretoria look for HHV8 in diffuse large B-cell lymphomas affecting HIV patients or not regularly.
You know, it has been something that we are doing more often on our cases of diffuse large B. As you know, Felipe, we have quite a large cohort of these lymphomas. So in the past, we certainly didn't do it as a routine, but I think more and more we're doing an HHV8 to screen for these patients, like we do an EBV for the EBV variant.
Yeah. Well, I believe that these were all the questions we've got for now. I'm quite sure that in the following hours or minutes, many other questions will appear, but we text you. And
no problem.
And thank you very much again, Liam. We're very, very grateful for your time, for your kindness, and for your expertise during this lecture, during this moment. And I personally, and I believe that's the same comment, I believe my colleagues may agree with me, we're very keen to meet you and all the Pretoria team in person again very soon. I hope that the pandemics allow us to meet you guys again, both in Pretoria and here in Brazil, in different cities. And as you showed us during your lecture, Pretoria is one of the most amazing cities that I've visited. And the University of Pretoria, it's superb, it's amazing. I really hope that our colleagues from Brazil have the chance of visiting Pretoria in the following years. Well, thank you very much again, Liam, for your talk. Very grateful.
It's my absolute pleasure. Thank you very much for the invite.
Thank you. Bem, pessoal, acho que por hoje era o que a gente tinha para dividir com vocês. Espero que vocês tenham aproveitado, gostado, né, dessa experiência. Eu gostaria de poder convidá-los mais uma vez para o próximo mês, né, para março. Nós teremos uma outra apresentação de alto nível, muito profícua, com certeza, da professora Caroline. Caroline, não me recordo sobre o nome dela, mas é da Universidade da Califórnia, certo? E sobre síndrome de Sjögren. Então, eu espero que vocês possam participar também, prestigiar a nossa colega que vai estar dividindo a experiência dela conosco. Bem, desejo um feliz final de semana, né? Aproveitem o sábado, o domingo, né? Um bom descanso para todos e a gente se encontra em breve mais uma vez. Um abraço forte e fiquem com Deus.